Assalamu alaikum everyone. Topic for today's discussion is X-ray interpretation. We'll also learn the basic terminologies of general radiography and qualities of a good X-ray. So let's begin. These are the outlines of the presentation: definition of X-ray, radiographic contrast and the factors affecting it, radiographic density, importance of anatomy in radiology, basic points when looking at X-ray, PA view, AP view, PA versus AP views, inspiration versus expiration X-rays, how to differentiate normal X-ray versus rotated X-rays. Then we will discuss some common terminologies like what is a silhouette sign, ATELECTASIS, consolidation, pneumothorax, pleural effusion, nodule, hyperinflation, loculated hydropneumothorax, importance of imaging in lateral decubitus position. How can you define X-ray? An X-ray is a quick painless test that produces images of the structures inside your body, particularly your bones. X-ray beams pass through your body and they are absorbed in different amounts depending on the density of the material they pass through. This is the first ever X-ray taken by Wilhelm Röntgen, who discovered X-rays in November 1895 with a piece of cardboard and a Lennard tube. He tested it on his wife's hand and saw the bones. There is a great saying that behind every successful man there is a woman, और in Urdu एक कामयाब मर्द के पीछे औरत का हाथ होता है, और ये वही हाथ था जिसने रॉयंटेजन को नोबेल प्राइज दिलवाया. He won the Nobel Prize in 1901 in physics. Exposure time of his first X-ray was about 15 minutes, while nowadays a modern X-ray image has an exposure time of about 10 milliseconds. You can see the difference between these two X-rays. Image contrast. It is the degree of photographic density difference between the two areas on a radiograph. We can calculate the contrast by taking out the difference between the densities of two adjacent parts. The formula is C is equals to D2 minus D1, where C is for contrast and D1 and D2 are the densities of the two adjacent parts. Factors affecting contrast. There are various factors which affect the contrast on imaging. Few important factors we will be discussing here. First is the region or the body part to be examined, as all the tissues have their own densities. Lesser the density, darker will be the image. As we can see in this X-ray, that air looks darker as compared to the soft tissues, as air has less density, while soft tissue looks lighter than the bones due to their lighter density compared to the bones. Second important factor is the kilovoltage applied. The higher the voltage from normal, the darker will be the image. Or we can say that the voltage applied is directly proportional to the darkness in the film. Normally, voltage applied in current modern X-ray machines ranges from 65 to 75 kVp. Third factor is the scattered radiation. Most important factor in production of scattered radiation is the field size. A small X-ray field, usually called narrow beam, irradiates less tissue and generates fewer scattered photons. X-ray beam enters the body and large number of interactions produce scattered radiation. Image contrast is reduced depending on the scattered radiation content which reaches to the film, as we can see in this image by comparing these 2 points. Left one is without scattered radiation and point with increased contrast, while the right point is with scattered radiations and with decreased contrast. Radiographic density. It is the measurement of film darkness and can be calculated by the log of division between X-ray incident on film and X-ray passed through the film. X-rays are the study of densities. Every tissue has their own density and as a result we get the image on the film. Comparing the tissue densities, air is the least dense. Then is fat, which is denser than air but lighter than liver. Then comes blood and afterwards muscles and bones. Lastly, barium and lead, which are most dense. Here we can see in this image and compare the color of element on X-ray in respect of their densities. The denser the element, the brighter it appears on the X-ray film. Air is the least dense, so it appears darkest of all, while metals have heavy density, so they appear bright white. Importance of anatomy. As an X-ray specialist, you need to have a good understanding of human anatomy, especially as it relates to identifying anatomical landmarks, positioning a patient correctly and comfortably for making the radiographic exposure. For understanding medical imaging, it is very important to have a basic understanding of normal anatomy, how they are altered by the disease or pathology, and how imaging plays a role in the diagnosis and management of the disease. Basic points when looking at X-ray. Whenever X-ray is handed to you, first thing you check is adequacy. And how can we check that? Firstly, we'll check for the adequate patient details: age, date of X-ray film taken, which side of limb is in film, is the exposure or contrast adequate or not. Then we'll see the part of a limb film follows the rule of two or not. Two views: posterior-anterior, antero-posterior, and lateral. Then two adjacent joints are visible or not, because in proper X-rays, ideally image taken should have one joint above and one joint below the site of injury. Two sides. It is important because in children we may confuse phases with a fracture, as the margin of phases is smooth, but in a fracture the margin is sought to be apparent. So generally in children we need X-rays from two sides. Two occasions or on different occasions, because sometimes fracture is not well defined at the time of injury. So repeat X-ray after few weeks and fracture is well defined. Classical example is a scaphoid fracture. Third is to look for a skeletal maturity. X-ray given to you is of a skeletal mature person or not, because many tumors are diagnosed based on the age, as there are certain tumors specific to age. Here in this image we can guess the age by looking for the ossification of certain parts of the bone. Like in the image below, we can guess the age of a child just by examining the elbow joint. The capitellum is the first of the elbow's 6 centers to ossify. Generally becomes radiographically visible during the first and second years of life. Initially spherical, it flattens posteriorly to the adjacent distal end of the humerus, and in the first image we can see this. In the X-ray of a 3-year-old, we can see the ossified radial head. At the age of 5 years, internal or medial epicondyle gets visible. Then at the 7 years, trochlea can be seen. 9 years age is identified by visibility of olecranon process. The last one to ossify an elbow joint is lateral epicondyle, which appears on X-ray at the age of 11. You can remember these ossifications by simple mnemonic curated. C for capitulum appears in age of 1 year. R for the radial head at 3 years. I for the internal or medial epicondyle at the age of 5 years. T for trochlea at 7 years. O for olecranon process at 9 years, and lastly lateral or external epicondyle at 11 years. Lastly, we look in X-ray for pathology for which the X-ray has been ordered, whether the area of the injury or pathology is clearly visible or not. There are a number of pathologies which can be diagnosed via X-rays. Can anyone guess this X-ray on the right? Which type of fracture is this? Great if your guess was Salter-Harris fracture. And you are a genius if your guess was Salter-Harris type 2 fracture. A Salter-Harris fracture is a fracture that involves the epiphyseal plate or the growth plate of the long bones. Posterior-anterior view or PA view. This is the standard radiograph of any patient. Posterior to anterior direction. Cassette lies on anterior and X-ray tube is posterior of patient. Rays travel posterior to anterior, done in a standing position. In PA radiograph, X-ray beams traveling parallel heart size is not magnified and film focal distance is greater. Here we can see the positioning for PA view. Scapulas are stretched to the side due to the positioning of arms. Antero-posterior view or IP view. This is not done as a standard practice, but can be done in bedridden patients, patients admitted in ICU and cannot move, in patients who are not able to stand due to their illness. Why is the AP view not practiced in chest X-rays? Because heart appears enlarged than the normal, because it is near to the X-ray source or away from the cassette. So the shadow will be the larger. X-ray beam is not parallel and is divergent, and heart size appears large. Film focal distance is also not much, and the mediastinum appears to be wider as compared to the normal. This is how AP view is taken. Most important point that should be remembered that the heart should never be commented in AP view. Why? Because heart appears magnified as we can see in this image below. So how can we differentiate X-rays of AP view versus PA views? These are the few points which I'll be discussing. Stomach bubble is usually visualized in a PA radiograph because of standing. In AP view, scapula lies within the lung field, while in PA view, scapula lies outside the lung field. Ribs look more horizontal in AP radiograph while ribs look oblique in PA view, but it is somehow difficult to identify this difference. In AP view, full inspiration is not possible and diaphragm will be raised. In PA, full inspiration is possible and diaphragm appears more flattened as compared to the AP radiograph. In this slide, I will tell you how can we differentiate inspiration versus expiration X-rays and their importance. Heart size is enlarged in poor inspiration. Crowding of vessels in lower zone is very common, which mimics patchy consolidations. We can differentiate by counting the number of anterior ribs. Number of anterior rib in good inspiration is usually more than 6, while number of anterior rib is usually less than 6 in expiration. How to know if the chest X-ray film is rotated or not? First is collarbone comparison. Check that the left and right collarbone are equal in length, and ideally both collarbones should be totally symmetrical. If one collarbone looks longer than the other, your X-ray is probably rotated. Second is a collarbone and spinal measurement. We measure between the collarbone and center spine, in which we draw a line down the center of the upper spine between the throat and the top of lungs. Then measure between each collarbone and this middle line. If one collarbone is significantly closer or farther to the central line than the other, your X-ray film is likely rotated. Third is a spine and chest wall. Measure between the spine and both outer chest walls. In a rotated chest X-ray, your spine might look like it's closer to the left or right side of your chest. We can also check rotation with upper spine. Check that the upper spine is straight and vertical. If the upper spine looks diagonal or uneven, your X-ray might be rotated. Heart size can also help to differentiate normal versus rotated X-ray. Examine the heart to see if it looks especially large or small. When the patient is rotated too much to the left, the heart might look bigger than it actually is. However, if the patient is rotated to the right, their heart might look a bit small. If the heart side doesn't seem accurate or consistent, there is a good chance that the chest X-ray is rotated. Soft tissue. Look for thick sections of soft tissue. When the soft tissue around the chest, like the breast tissue, looks extra thick, doctors might assume that the patient has some kind of lung disease. If this happens with your X-ray, there is a chance that the image could be rotated. Rib cage. Check that the left and the right rib cages are even in size. If one rib cage looks larger or more prominent than the other, the chest X-ray might be rotated. Asymmetry. Even if there is some asymmetry, the X-ray might not be rotated. For instance, the hilar points, diaphragm and trachea will not always look symmetrical. This point is very important if you are doubtful of any X-ray to be rotated. Cross-check with other X-rays. Cross-check other X-rays to see if everything adds up. It can be hard to get full picture from a single X-ray. Before jumping to any conclusions, compare the chest X-ray to any other images that were submitted. These can help you see the full picture instead of just what the chest X-ray is showing. And the last one is penetration. In addition to the lack of rotation, a good X-ray will also have adequate penetration. Penetration, also called exposure, describes how deeply X-rays pass through the body. In properly exposed chest X-ray, the vertebrae are visible behind the heart. If the film is underpenetrated, you won't be able to see the left hemidiaphragm and can't assess the lung tissue behind the heart. These are some common terminologies used in radiology. We'll discuss them one by one. Silhouette sign. When two objects of same density touch each other, the edge between them disappears. In radiology, the silhouette sign refers to the loss of normal borders between the thoracic structure. It is usually caused by an intrathoracic radioopic mass that touches the border of the heart or aorta. In other words, it is difficult to make out borders of a particular structure, normal or otherwise, because it is next to another dense structure, both of which will appear white on a standard X-ray. It may occur, for example, in right middle lobe syndrome, where the heart right margin is obscured, and in right lower lobe pneumonia, where the border of the diaphragm on the right side is obscured, while the right heart margin remains distinct. Silhouette sign is very useful in localizing lung lesions, as all structures forming cardiac silhouette are in contact with a specific portion of the lung. Here in this image, we can see that the left hemidiaphragm is invisible due to the consolidation in the left lower lobe, while in image B, the right hemidiaphragm is poorly seen due to the consolidation in the right lower lobe. An interface is not visible when two areas of similar radiodensity touch. Atelectasis, collapse or volume loss. To diagnose atelectasis, there must be evidence of volume loss, such as displacement of a fissure or hilum. Tension pneumothorax. A tension pneumothorax is a life-threatening condition caused by pleural injury, which acts as a one-way valve. As a result, air can enter the pleural space during inspiration but is unable to escape during expiration. The accumulated air in the pleural space compresses the lungs, blood vessels, and other structures of the chest cavity. Here you can see the X-rays of a 47-year-old male with a history of fall. There is a large right-side pneumothorax, marked contralateral shift of the mediastinum, hyperinflation, obvious flattening of the right hemidiaphragm with a pulmonary contusion. The other chest X-ray is a repeat chest X-ray, demonstrating partial lung reinflation and midline mediastinum with a multiple right-sided rib fractures, right clavicular fracture, and the resolution of the hyperinflation. Pleural effusion. A pleural effusion is an unusual amount of fluid around the lung, sometimes referred as a water on lungs. There is a buildup of excess fluid between the layers of the pleura outside the lungs. Loculated hydropneumothorax. A loculated hydropneumothorax is a form of pneumothorax where a pocket of air and fluid is trapped within a pleural space. Pulmonary nodule. A pulmonary nodule is a small, roundish growth on the lung, sometimes referred as a spot on the lung. It is easy to find and hard to diagnose. Hyperinflation. Excessive, large, or heightened increase in the lung tissues. Image on the left demonstrates the X-ray of a patient of a COPD with marked hyperinflation of the lungs. X-ray on the right is hyperinflation because of asthma. Lateral decubitus position. The lateral decubitus radiograph is used to identify free gas or fluid. It can be performed when the patient is unable to be transferred for the other imaging modalities, like if a CT is unavailable. The most useful position for the detecting free intraperitoneal air is the left lateral decubitus position. Chest film on left is of right lateral decubitus view of a 40-year-old male with a hemopericardium and pleural effusion. The other X-ray on the right is initial abdominal film in left lateral decubitus position, demonstrating large amount of free air with black arrows and dilated loops of the bowel pointed by the double white arrows, and inferior and medial displacement of the liver, also called Saddleback sign, demonstrated by the triple clear arrows. Now we'll be looking at few X-rays. Try to diagnose what is in the X-rays by yourself and do write about your diagnosis in the comments. This is the first X-ray. Can you spot what the arrows are showing? This is the second X-ray. This X-ray shows chest as well as abdomen. What can you see in this? This X-ray clearly shows keys in the center. Let's see how you people can explain this X-ray in your comments. And this is the last one. Let's see what are your answers. We'll discuss all the answers in my next video regarding chest X-rays. That's the end of the presentation. Inshallah, we'll meet soon in a new video with a new topic. Take care. Allah Hafiz.